A very good evening and a warm welcome to everyone to IS PG class. These classes
There is. Excuse me. I think she's not audible.
Her network is not stable.
She's not audible. Nishant,
Pranita, can
Yes.
I think we will have to take over.
Not a problem, ma'am.
which will be discussed today.
A very warm welcome to everyone and a very warm welcome to the ICI Online PG classes.
Before we start the session, let us invoke the blessing of Ma Saraswati.
Oh my God. One sec.
Nishant, I think you can play the Saraswati Vandana. Her network is not stable. Vishali's.
So let us invoke the blessings of Mata Saraswati and after invoking the blessings of Mata Saraswati, may I request our Honorary Secretary ICI National Sukhminderjeet Singh Bajwa sir to please introduce the class and the speakers for the day.
Thank you, Dr. Nishant. Don't have to introduce the speaker. They are very well known. The moderators, not the speaker. Speaker is a PG student, Dr. Neeta Bose and Dr. Dharatana. They are well known for their academic credentials. And regarding the class, actually, this is not just a class. It's about the practical scenario also. The difficulties you encounter in a day-to-day practice, especially in the obstetric patients, with all the cardiac ailments and such patients present for the surgical intervention. The anesthetic management becomes very complicated in the cardiac ailments are also of a highest degree. Not just to the limited to the operating room. These patients may sometimes land you up in the critical care units also. So that's where the anesthesiologists score over other clinicians, right? From the managing, from the entry of the patient to the hospital, then taking care till the discharge of that patient. I think those are the biggest roles an anesthesiologist as intensivist play in management of such patient. And I think it's a common scenario throughout the country. Many patients come for surgical, especially the emergency patients, and later on they require the intensive care admission. And it's good that the same team which was managing the anesthesia management during the surgery, they will be managing these patient intensive care unit or under their guidance. So today we will be having such a case. It can come as a long question. It can come as a short case or a long case, whatever. But these cases are very practical, not for the PG students, but for the later part of your life also, whether you are practicing or you are in institution. So without wasting time, I hand over the mic back to Dr. Nishant and the other team, and Dr. Madhuri and Dr. Nishant, our class coordinators. And today we have got two young moderators, Dr. Vaishali and Dr. Pranita. I think because of some connection problem of Dr. Vaishali, Dr. They will both be, I think, coordinating with each other.
Yes.
Back over to you, please.
Thank you, sir. Dr. Vaishali, do we have a connection back? Unmute yourself, please.
Nishant, Dr. Pranita will introduce this faculty.
Okay, she has the series?
Yeah, she has.
Yes.
She will
Great.
take. Yeah.
Okay, Dr.
Hello,
Pranita.
everyone. Hello, everyone. A very warm welcome to all my respected seniors, my respected teachers, my colleagues, and all PG students. Welcome to ISA Online PG class. It gives me an immense pleasure to introduce our eminent faculties of national repute. Our board moderators are very dedicated and recognized PG teachers. I welcome our first moderator, Dr. Neeta Bose, ma'am. She is currently serving as an associate professor at in the Department of Anesthesia at GMERS Medical College and Hospital, Vadodara, Gujarat. She has worked as professor in Department of Emergency Medicine as well. She has been past president of the ISA Vadodara City branch. She has been past chair of ISCCM Vadodara City branch. Ma'am is an AHA accredited BLS ACLS instructor. She is also IRC BCLS CCLS instructor. Along with it, ma'am is also an ATLS instructor. She has played major role in organizing state as well as national CMEs and conferences. She has been esteemed faculty at various conferences and CMEs. Her areas of interest are difficult airway management, critical care, USG in anesthesia, ICU and emergency. Now I welcome our second faculty of Dr. Dharatanna ma'am. Currently, she is working as an associate professor in Department of Anesthesia at GMERS Medical College and Hospital, Vadodara, Gujarat. She is an active member of Vadodara City Branch ISA. Currently, she is serving as an executive committee member of ISA Vadodara. Ma'am has done her fellowship in pain management. She is ISA IRC BCLS instructor. She is also a member of Institutional Curriculum Committee. She has several publications in national and international journals. She has written 2 book chapters as well. Her areas of interest are regional blocks, USG guided nerve blocks, obstetric anesthesia, and pain management. It's our privilege to have esteemed faculty amongst us today for the session. There are few instructions for the audience which I'll tell you. You all will be muted for the duration of the talk and you can type your queries in the chat box. Question will be answered at the appropriate time at the end of the session. I kindly request all audience to keep your video off for the duration of the talk. Now I hand over stage to Dr. Neeta ma'am to introduce a resident for the today and take over the session. Thank you so much.
Thank you, ISA National, for giving us this platform to present this case discussion. I am very much honored for this responsibility which has been given to me. And I hope I can do the best of it and let the PGs learn as much as possible they can. And kindly come up with your questions. Every question is welcome. I think we welcome the questions because that's how we learn more. I would like my resident, who is third year resident, Dr. Zalak Patel, to present with the case, and we will be discussing the points in between, and certain discussions will be held at the end. Over to you, Zalak. Please start.
Sir.
Good afternoon, everyone. I'm Dr. Zalak Patel, third year resident at GMERS Medical College and Hospital, Gotri, Vadodara. We will discuss a case about peripartum cardiomyopathy today. So my patient is a 26-year-old female weighing 60 kg, primary gravida, 36 weeks period of gestation with a twins pregnancy. She was diagnosed with pre-eclampsia at 30 weeks and she was on a tablet labetalol 100 mg twice daily for 20 days. She presented in an emergency at a private hospital with sudden onset of breathlessness since 2 days and pedal edema since 10 days. She was relatively asymptomatic before presentation of these complaints, and her breathlessness was increased on the day of presentation. She was also she was kept on NRBM there for a few hours and then referred to the GMARS hospital. On examination, patient was conscious oriented and she had symptoms of respiratory distress. Her pulse was 108 per minute regular, RR was 28 per minute, blood pressure was 160 by 110 millimeter of mercury, saturation was 93% of 50 liter NRBM. She had bilateral pitting type of pededema and her urine albumin was +3. On auscultation, crepitations were heard all over chest and there was no murmur. So patient was stabilized by giving injection labetalol as an antihypertensive with 20 milligram. Injection Maxelf loading dose 4 gram IV was given. She was not maintaining saturation or 50 liter NRBM. So call was given for the anesthesia team for further management, which was given within an hour. Immediately as an management, she was kept on a BiPAP support with FiO2 of 80% and high P. And because her blood pressure was remaining on the higher side, she was given injection labetalol 40 milligram and injection furosemide 10 plus 20 milligram IV step. Injection Maxelf 1 gram per hour as a maintenance dose was started. After 2 hours of BiPAP support, her pulse was 106 per minute regular, blood pressure was 140 by 108 millimeter of mercury, saturation was 99% on BiPAP, and her in auscultation, her RS has bilateral capitations. Bilateral lowers of crepitations. So baseline investigation, her CBC complete blood count was normal, but her creatinine was somewhat on higher side with the increased potassium levels and deranged PT-INR. Her SGPT level was also somewhat on the higher side. Her ECG was normal, D-dimer level were raised and LDH level were also raised. On further investigations, ultrasound showed 1 live fetus and 1 IUFD. So depending on the clinical scenario, that her vitals improved and she was primary gravida. With the consultation with the obstetrician, she was induced for normal vaginal delivery with injection oxytocin and with the regular fetal heart rate monitoring. So based on clinical scenario and investigations, we had differential diagnosis of severe preeclampsia with pulmonary edema with HELLP syndrome, severe preeclampsia with cardiac disease, which may be valvular heart disease or peripartum cardiomyopathy with symptoms of heart failure, and severe preeclampsia with pulmonary embolism. So on further diagnose the patient, we had advised chest X-ray and 2D echo. Physician and cardiologist opinion was taken as a multidisciplinary approach. IV fluid restriction was advised with the keeping in check the balance of the IV fluids. Correction of potassium and coagulation profile was also advised, for which 4 FFPs and 2 cryoprecipitates were transfused. Monitoring of blood pressure and for controlling of blood pressure, tablet labetalol was given, SOS injection labetalol was given. And her arterial blood gas analysis was advised at regular intervals. So our 2D echo showed dilated cardiomyopathy with dilatation of left atrium, left ventricle, and right atrium, with ejection fraction of 30% and global hypokinesia. She had moderate MR, moderate TR, and moderate pH with right ventricular systolic pressure of 49 millimeter of mercury. Her baseline ABGA was somewhat normal with pH of 7.41 and PCO2 33. Her PO2 and saturation was normal. Chest X-ray showed moderate cardiomegaly. So based on these clinical features and further investigation, we had come to a conclusion that patient is having severe preeclampsia with peripartum cardiomyopathy with heart failure with partial HELLP syndrome. So during next 24 hours, we had kept the patient on a BiPAP support only, and she was her potassium and PT-INR was corrected, which values are shown here. She was given furosemide 20 milligram twice daily as an treatment, and vitally she was stable on the BiPAP support. On auscultation, her RS had bilateral capitations or lower zone only, and her respiratory rate was 20 per minute. Her fluid balance was kept on the negative side, and magnesium sulfate infusion was stopped after 24 hours in the evening of the same day. So next morning on examination, patient was feeling better. Her breathing pattern was improved from rapid shallow to normal breathing. Her pulse was 90 per minute. Blood pressure was 144 to 90 millimeter of mercury. Saturation was maintained and RR was also stable, that is 20 per minute. Her RS was clear and she was maintaining adequate urine output. On investigations that day, her all investigations are normal except for creatinine, which was on the increasing trend. But due to non-progression of labor, patient was taken for emergency lower section cesarean section. For anesthesia management, we had induced the patient in general anesthesia with injection etomidate and injection of fentanyl. For maintenance, oxygen and air, 50% each was given with sevoflurane, and for muscle relaxation, ectraquetone was given. For analgesia, further analgesia, injection paracetamol was given. Intraoperatively, her vitals were remained stable. Urine output was 100 ml in 1.5 hour duration of the operation. Blood loss around 700 ml, and 1 unit of blood was transfused intraoperatively. She was given injection furosemide 20 milligram after delivery of baby, and uterus was well contracted. So after OT, she was shifted intubated to the OBS ICU, and she was kept on the mechanical ventilation, that is CMVC. After a few hours postoperatively, her vitals remained stable. BP was also around 140 by 90 millimeter of mercury, and urine output was maintained around 50 to 60 ml per hour. But around evening, her systolic blood pressure dropped, that is 90 to 100 millimeter of mercury, and she had lower urine output, that is 20 to 30 ml per hour. So inotropic support was started, and she was also given fluid challenge, for which patient responded. So based on the improvement of the blood pressure and urine output, the inotropic support was tapered off in 12 hours. She had developed fever that night, and her post-operative investigation showed hemoglobin, which was on the lower side, 8.5. Platelet was also decreasing. Creatinine, which was on the increasing trend, and albumin, which was on the lower side. She was advised for injection paracetamol and injection calcium thrice daily basis. Her fever profile, cultures of urine, blood, and ET were sent, and higher antibiotics were started. Next day, her fever continued, but she was vitally stable. She was weaned off to the synchronized ventilation, that is SMVC, under sedation. On examination, we noted that there was increasing in abdominal girth, and on further ultrasound findings, which suggested that it may be ascites or hemoperitoneum. And also there were decreasing CBC count, that is hemoglobin and thrombocytopenia was there. And albumin also on the lower side. Dengue and uric culture were negative. The cardiologist opinion was taken, for which he had advised that fluid restriction should be there, and serum creatinine levels should be monitored regularly with the urine output. Injection LMWH and injection albumin was advised, and blood products, if they are given, should be given under cover of injection furosemide. So 1 PCV and 4 PCV were transfused for that day. She was given brief CPAP trial, but she had a lower tone and power. So her synchronized ventilation was continued. On day 4, her frequency and intensity was decrease of fever. Synchronized ventilation was continued. She was vitally stable, and on examination and also USG, her abdominal girth reduced, and urine output was maintained. Hemoglobin further reduced, for which 2 units of blood were transfused with under cover of injection furosemide. Platelet and serum creatinine shows improving trend, and serum calcium was on the lower side, for which correction was given. Next day, her condition further improved. There was visible reduction in edema and abdominal girth. Vitally was stable, and her muscle tone was normal. Creatinine and urine output further improved, but sodium was on the rising trend. So IV fluids were given as a 0.45% NS and for D 5%. She was, as her condition was stable, she was extubated and kept on BiPAP support with FiO2 40% and higher beeps. She was vitally stable after extubation. Injection LMWH and calcium gluconate was started. Peristalsis were present, so she was given clear water via RT, that is 50 ml 2 hourly. On further next 2 days, she was weaned off the BiPAP and kept on the intermittent BiPAP support if required. And on the 7th day, she was kept on the NARBIM support throughout. So on the 8th day morning, she was stable. She was kept on the face mask and she was conscious. But suddenly she went unresponsive, and after brief tachyarrhythmia, her pulsation was not palpable. So immediately CPR was started and she was intubated. She showed ventricular tachycardia. The rhythm showed ventricular tachycardia. So 200 joule of DC shock was given, and there was spontaneous return of spontaneous circulation with palpable radial pulsation. She was kept on the control ventilation. And post resuscitation vital showed pulse 108 per minute regular. Blood pressure 120 by 78 millimeter of mercury. Saturation 199%, and in RS auscultation bilateral capitations were heard. Post-resuscitation, 2D echo was done, which showed ejection fraction of 35 to 40%, moderate LV systolic dysfunction, left ventricular and left atrial mildly dilated with mild PAH, RVSP of 37 millimeter of mercury. Similar episode of ventricular tachycardia occurred after 12 hours of first collapse, but a return of spontaneous circulation was present after giving one DC shock. The radial artery pulsation after that were feeble, and she had low blood pressure, for which she was started on the inotropic support, that is injection noradrenaline, and potassium which was somewhat on the higher side, and calcium magnesium which were on the lower side after resuscitation, where correction was given. On the next 2 days, she was kept on the ventilation only and weaned off gradually to the SIMV-VC mode. And her inotropic support were tapered off in around 12 hours after measuring the blood pressure. And the blood pressure after that was somewhat remaining on somewhat the higher side, that is 140 to 150 by 90 to 110 millimeter of mercury, for which she was given injection labetalol as an antihypertensive, which precipitated arrhythmia in these patients, so it was held. She was advised for starting TPN, total parenteral nutrition, and for correction of electrolytes. Injection LMWH were again started after the collapse, and injection amiodarone as an anti-arrhythmic agent were advised. Injection furosemide was continued. During next 2 days, she was gradually weaned off, extubated, and kept on the BiPAP support, which was also tapered off in the next 2 days, and she was stable throughout. For antihypertensive, she was given tablet amlodipine 5 milligram twice daily. Injection tablet Lasix and tablet Electron was added in the treatment. Injection amiodarone was kept on hold as she had brief 2-3 episodes of ventricular tachycardia. Electrolytes were corrected and fluid balance was kept on the neutral side. So she had improving investigation after the 3-4 days of the extubation of the second arrest. And her 2D echo also showed improvement, then in which ejection fraction was 45 to 50% and mildly LV dilated only. So after that, patient is kept tapered off of the oxygen and still awaiting discharge. So to summarize my patient, on day 1, she came with a complaint of severe preeclampsia, acute heart failure. And for treatment, we had given antihypertensive diuretics, BiPAP support, and she was induced after the stabilization for normal vaginal delivery. On day 2, her vitals somewhat improved from the previous day, but there were no progression of labor, so she was taken for the emergency cesarean section. Post-operatively, she had developed fever, hypotension, oliguria, inotropes, and her hemoglobin was on the lower side. So the differential diagnosis may be that she may be in the sepsis, or she may be bleeding, that may be postpartum hemorrhage, or she may go into acute renal failure, or there may be HELLP symptom. On third and fourth day, her ventilation was continued, but she had developed visible ascites or hemorrhages because of low hemoglobin and also decreasing platelet counts and low albumin levels. Therefore, that injection albumin and blood products were advised. Electrolytes were corrected. On day 5, she was extubated and kept on the BiPAP support. Sodium was increasing, so she was advised for 0.45% or D5% as an IV fluid. And for further 2 days, she was stable. On day 8, she had polymorphic VT and she was collapsed. So spontaneous circulation was present after cardioversion. She was again intubated. Brief inotropic support had required, and antiarrhythmic were started. Electrolyte correction was given throughout. On day 11, she was again extubated and kept on the BiPAP support, and gradually she was tapered off of the oxygen, and her 2D echo also showed improvement, and investigation was also improved. And now she is awaiting discharge. Thank you.
Okay, thank you, Dr. Jhalak. So after so many ups and downs, now patient is stable and awaiting discharge. Yes. So our patient presented with dyspnea and crepitations with pedal edema. So what was your first impression when you saw this patient?
Ma'am, in preeclampsia, there may be in pregnancy, normal pregnancy, pedal edema is present in most of all the patients. But dyspnea, the complaints of dyspnea and crepitation were present, which are mainly complications of pulmonary, which are complication as a pulmonary edema, which may be a complication of preeclampsia, or there may be a heart failure because of any cardiac condition, which may be present beforehand, or which may be a new onset.
Yes. So this kind of features like dyspnea, orthopnea, edema, etc., they can be there in pregnancy itself in the last trimester. So we have to keep high index of suspicion to rule out these symptoms because of pregnancy, or if there is some underlying cardiac condition present. Yes. So this patient had severe preeclampsia. What is severe preeclampsia?
It is preeclampsia is basically increasing blood pressure more than 140 by 90 mmHg after 20 weeks. In severe preeclampsia, it is raised to 160 and diastolic to 110 by mmHg. And there is a presence of proteinuria, which is 2 gram per 24-hour urinary sample, or 2 plus dipstick sample, which is made obtained after 4 hours apart. And there may be presence of end organ damages like liver damage. There may be increase in the SGPT levels, and bilirubin level may be raised to more than 1.2 milligram per deciliter. There may be presence of right hypochondrial pain. Also, nausea, vomiting may be present. CNS symptoms like headache, blurring of vision may be present. And thrombocytopenia is present, that is platelet count less than 1 lakh. Hemolysis, features of HELLP syndrome like hemolysis also may be present with decreasing hemoglobin count and increasing LDH level.
Okay. So this patient had preeclampsia and some features related to cardiac disease. So how will you differentiate severe preeclampsia with that patient having underlying cardiac disease which is pre-existing? Or what can be the differential diagnosis at this point of time when you are awaiting further investigations?
Okay, so based on clinical features, first of all, she had all the features of heart failure. So we can conclude that patient might be having any cardiac disease. If it is pre-existing, then patient may have any prior documentation like 2D echo or any prior visit to cardiologist, or she may have a complaint of if it is valvular disease, then she on auscultation she murmur may be heard. Then if valvular heart disease, then she may have replaced it. I mean, she may have a history of replacement of it. And based on clinical features, we can conclude, we can come to these differential diagnosis. And also with the decreasing platelet count and hemolysis, she may have a HELLP syndrome.
Yeah, so we are yet awaiting investigations. So now at this point of time, when we don't have any investigations in our hand, what can be your plan of action here?
So first of all, based on clinical features, we should, I will stabilize the patient for blood pressure is on the higher side. So I will give antihypertensive like injection labetalol, which is safe in pregnancy. Also, blood hypoxemia is there. Patient is not maintaining saturation on BiPAP, on NRBM. So BiPAP support is given. And for this patient who has come to us with the features of heart failure, so the patient may be in a overload condition. So I will give injection Lasix, which we have given in this patient. Injection furosemide, which decreases the after preload also, and decreases the strain on the left ventricle.
Okay, so this is about medical management of the patient, but patient is 36 weeks gestation. Any
Yes.
plan related to this?
So 36 weeks is a after viable age of fetus. So if mother is not stable, and if it is a patient, if fetus in the distress form or fetal heart rate are decreased, then we can take patient for emergency cesarean section. Or our patient had somewhat stabilized and she was primary gravida, so we had induced for normal delivery.
Okay, so delivery as soon as possible may help improving patient's condition. So this thing is to be kept in mind.
Yes, ma'am.
Okay, so what can be the merits and demerits of normal vaginal delivery versus emergency C-section in such patients?
So for normal for any surgical intervention, like in a cesarean section, we there is a exposure to anesthesia. That is, if it is central nerve block or even if it is general anesthesia, there is exposure to anesthetic drug which have adverse effect on the cardiac fibers, and also it has adverse effect on the fetus also. So this is the adverse effect of anesthesia is not there in the case of vaginal delivery. And the pain or post-operative pain, which is for the incision, which is not there in case of vaginal delivery also. And acute hypotension, which may be there, which is an adverse effect of neuraxial block, which can be prevented in case of normal vaginal delivery. And labor, duration of labor is prolonged in case of normal vaginal delivery, which can cut off in case of cesarean section. And
so yes,
if-
we have to see the patient and the condition of the fetus and decide accordingly whether we have time for further investigation and stabilization or not. Okay. Now, what if this patient has fetal distress and you don't have any time for further stabilization or investigations? So what will be your choice of anesthesia?
Based on the clinical condition, and if patient comes with the fetal distress, and I will definitely go with the general anesthesia only. And for that, drugs which we are we'll use the induction agent or maintenance agent, which are less cardiodepressant on the patient.
Yes. So in that condition, you will not have time to stabilize the patient. So with the
Yes, ma'am.
acute LVS, you have to take the patient in surgery. Yes.
ma'am.
Okay. In one of the differential diagnoses, you said severe preeclampsia with query HELP syndrome. Why you put a diagnosis of HELP syndrome, and how will it make a difference knowing that this patient may go in HELP syndrome?
HELP syndrome is a complication of preeclampsia, and basically it is mostly for the prognostication of the patient survival.
Okay.
And this patient had increase in borderline increase in the liver enzyme, and also there is evidence of hemolysis, like increase in D-dimer level and LDH level. So we had with the prognosis of HELP syndrome.
Okay.
So
So
how does it help to know that the patient has a HELP syndrome? Does it make a difference in your management or prognostication?
So no, not in management. Management is based on the symptoms of heart failure and also the dilated cardiomyopathy only. For HELP syndrome will help in the prognostication of the survival of the patient.
Yes, there's a higher mortality with HELP syndrome compared to the preeclampsia patients, right?
Yes, ma'am.
yes, and this patient may show a decreasing trend in platelet count as it has happened with our patient. So we have to keep in mind the bleeding tendency related to HELP syndrome and other things. Yes. So now, if we have time for stabilization of the patient, what investigations will you advise?
So we had advice for 2D echo for like for basic starting from the basics, complete blood count, then LFT, RFT, serum electrolytes, and 2D echo and ECG and X-ray, chest X-ray for basic investigations. For if we have time for further investigation, then 2D echo is advised and chest X-ray to know if there are any effusion or any signs of congestion are there.
How will 2D echo help in this patient?
So before 2D echo, we don't know if it is valvular heart disease or like structural abnormality, or if it is any other form of cardiomyopathy. So to differentiate that, 2D echo is helpful. In case of dilated cardiomyopathy, the chambers are dilated, dimensions are increased. There may be reduced in ejection fraction. And in case of any other type of or structural abnormality, like a valvular heart disease, it may be present in their 2D echo.
Any other investigation apart from echocardiography will help in supporting your diagnosis?
We can also do the blood level of pro-BNP levels, which are increased in case of cardiomyopathy. And MRI can be done to diagnose the structural anomaly which is present in the heart. And also genetic testing can be done in case of
Well, that will be later on, but at least primarily an echo will definitely help you, right, to differentiate from the other cardiomyopathies.
Yes, ma'am.
NT-proBNP, though not a specific biomarker for peripartum cardiomyopathy, but it will definitely show that there is some element of ventricular failure. Yes. So now after 2D echo, this patient, where our diagnosis was dilated cardiomyopathy, peripartum cardiomyopathy. So what is peripartum cardiomyopathy?
Peripartum cardiomyopathy is a reduction, or there is a reduction in left ventricular function, or which is less than 45% because of any other reason than the any pre-existing cardiac disease which is present in last month of the pregnancy, or in the last trimester, which can continue or which can be diagnosed after delivery within 5 months after delivery.
Yes. So, it is now, it has become a leading cause of maternal death. And yes, most of the patients, they present during the last trimester of pregnancy, and later on also postpartum can also they present. And they usually present not just with left ventricular failure, but they can present with one of the complications of cardiomyopathy like arrhythmia or even thromboembolic events. So diagnosing peripartum cardiomyopathy becomes very tricky because the features are seen in even late pregnancy. So yes, 2D echo will definitely help in ruling out other things. What are the risks?
It is there in post-delivery also. So patient may not present right at the time. Patient will have some presentation later on. That is also possible, right? So these patients will have a longer follow-up, and high index of suspicion will be there for such patients, right? Correct.
What are the risk factors for development of peripartum cardiomyopathy?
So for this, basically, in 5 to 20% of patient hypertensive disorders, particularly preeclampsia, is a major risk factor. And other than that, multi-gestational pregnancy, multiple pregnancy, then advanced maternal age, obesity, anemia, these are also risk factors. And any familial history or genetic disorders also are causes peripartum cardiomyopathy.
So your patient was having any risk factor?
Yes, she had twins pregnancy, which was multiple gestation, and also she had preeclampsia, severe features.
Right.
Okay, so what pathophysiological changes are seen in patients with peripartum cardiomyopathy? What is the hormonal background behind this?
Okay, so primarily, pregnancy itself is a physiological stress for the patient. And in case of preeclampsia, there are increasing in hormonal levels, which are basically not in non-pregnant female without any preeclampsia, which are not somewhat on the lower side. So these on hormonal basis, the hormones like prolactin, progesterone, inhibin A, they can affect the cardiac myocyte via indirect or direct action, and they lead to injury to the vascular endothelium, and these leads to ultimately ischemia also, and reduction in the blood supply. And there is also release of miRNA, which can be taken up by myocytes, and this leads to apoptosis of myocyte, and it can lead to left ventricular dysfunction.
Okay, so in this case, patient had preeclampsia and twin multiple gestation. So there is an epidemiological evidence that because of large increase in placental secretion of soluble FMS like tyrosine kinase 1, which triggers cardiovascular damage. So probably that's why this patient was very high risk for development of peripartum cardiomyopathy.
So generally these patients have what kind of failure they have? The patients of dilated cardiomyopathy?
So there is a systolic dysfunction in these patients.
And versus the other cardiomyopathies that you know of. So what kind of dysfunction do they have?
Yes. The other types of cardiomyopathy that is acquired, they may be acquired or inherited. We are discussing about dilated cardiomyopathy, which is in which post peripartum cardiomyopathy is included. There is hypertrophic cardiomyopathy, in which there is a hypertrophy of wall of the left ventricle, or there may be a hypertrophy of a septum of the interventricular septum. And if it is hypertrophied the wall thickness is more, then it can cause outlet obstruction, left ventricular outlet obstruction. So other is restrictive cardiomyopathy, in which there is an increased myocardial stiffness because of infiltration in case of like amyloidosis or sarcoidosis, and this causes decrease in relaxation of myocardium. So these hypertrophic cardiomyopathy and restrictive cardiomyopathy has dilated diastolic dysfunction, and DCM has systolic dysfunction.
Yes.
Other
Which is worse, systolic or diastolic?
it's systolic.
Yeah. No, why would you say systolic is worse? Because
it reduces ejection fraction also. So
yes,
cardiac
so
output is
Cardiac
reduced.
output.
absolutely, absolutely correct.
Okay, in this patient, if we talk about cardiac function, which factors complicate peripartum cardiomyopathy?
In this patient, the patient is of pre-eclampsia. So hypertension is there. So afterload is there. Afterload is increased, and patient came with the feature of heart failure. So circulatory volume is also overloaded. So preload is also increased, which can further causes reduction in left ventricular function.
Yes, as such in pregnancy, there is increase in the blood volume. So the overall blood volume is increased, and more so with twin pregnancy. So this can increase preload, and this further complicates rise in blood pressure due to preeclampsia. Yes. So how do you manage a patient with preeclampsia with peripartum cardiomyopathy? What goals you keep in mind?
So our goal is to primarily reduce preload as well as afterload to decrease the strain on the left ventricle, and also prevention of eclampsia, converting pre-eclampsia to eclampsia. So for that, we are giving the antihypertensive which reduces the afterload, and we are giving fluid restriction, and also preventing pulmonary edema or treating pulmonary edema with injection furosemide or any diuretic.
So
Which
basically what you're trying to maintain is that patient should not have a problem in a forward flow, as well as there should not be something which is, the heart doesn't push and it has to throw backwards, right? So you're trying to prevent the failure element, as well as you're trying to get the cardiac output right, isn't it?
Yes, ma'am.
Right. Fine. So, like when you are dealing with such kind of patient, so like how would you approach this patient? Alone, or do you like get a reference done? Whom would you contact for that? What kind of approach would you have for these patients?
So multidisciplinary approach should be there to involve obstetrician also, anesthesiologist, cardiologist, or physician.
And even neonatologists, right? Because ultimately the babies are small for date and they will require, so whatever is the best for either the mother, the baby, that has to be taken in toto and seen, right? And cardiologists, better to ask for involvement of cardiologists right from the beginning. Otherwise, then what kind of drugs to go on, what therapies to start, and ultimately they are going to be a long-term patient with the cardiologist, right? So now, like this patient, ultimately a patient was on non-invasive ventilation, and then you next day decided to go for the cesarean section, right? So like, is cesarean section better or a normal delivery better? What is recommended?
So it depends on the condition of the patient, and also the age of viability of the like period of gestation of the fetus. If a patient is stabilized, and if fetal heart rate monitoring is there, and appropriate preparation for emergency cesarean section is also there, then we can go for normal vaginal delivery. Otherwise, if mother or fetal compromise is there, then we should go for emergency cesarean section.
What problems can happen with cesarean section? Like, suppose you want to give, like you gave a fair trial in this patient, right? For a few hours for the normal delivery. So what problems can you anticipate in a CS if, this patient has to be undertaken for that?
If like this patient will definitely, according to the features and 2D echo findings, that low ejection fraction, she will be induced under general anesthesia. So after, in case of in pregnancy and particularly in preeclampsia, the edema is there. The pulmonary edema and also respiratory edema is there. So in induction, during induction, in case of general anesthesia, patient there may be difficult intubation. Then because of the patient had a HELLP syndrome and coagulopathy was deranged in the starting, so there may be a bleeding during intubation only. Then
So basically, you are telling me like why general, would you have prefer general anesthesia, right? So I mean, why is regional so risky in these patients?
If ejection fraction is normal, then we can go. If patient is stable, her blood pressure is normal, her vitals are normal, her RS is clear, respiratory rate is normal, then we can go. But her ejection fraction was on the lower side, and she had acute failure. She was in acute failure, so we should go for
Yeah, so
generalized.
when patient is in acute failure, you need to take control of the RS and regional anesthesia. Suppose patient was not in failure also, if you try to give regional anesthesia, you are going to have a drastic fall in the hemodynamics, and that will again make her unstable, right? So like, so since you have planned for general anesthesia, what what goals are you going to keep in mind throughout the patient and at the induction? What is the basic goals in your mind during the anesthetic management?
So hemodynamic stability should be maintained throughout. Like blood pressure and heart rate should be kept within normal. There should not be any bradycardia or tachycardia, and hypotension and hypertension also. Bradycardia, if there is bradycardia, then it decreases the cardiac output. The patient is already had low cardiac output, so it will be detrimental. And in case of tachycardia, the diastolic feeling is not there, so again it will reduce the cardiac output. In case of hypotension, the organ perfusion is hampered, as basically this patient in preeclampsia, this patient was on the BiPAP support, and she was on the injection furosemide also. So there may be a component of hypovolemia, and in case of hypotension, organ perfusion may be less, which can cause a decrease in urine output, and ultimately the acute kidney injury might be there. And in case of hypertension, the patients are the hypertension causes increase in afterload, so it will keep this. It will cause this strain on left ventricle ejection also, left ventricular function. And then patient might go into the heart failure, and also these patient may precipitate in case of hypertension eclampsia also.
Right. And I mean, why you think these patients are, very much prone to hypotension, even though they are always presenting with hypertension, right? They present with hypertensive failure. So, but why they are so much prone to hypotension?
So if we are giving anesthetic agents, our anesthetic agents are vasodilatory, and also there is a chronic hypertension in this patient. So there might be overt hypotension after giving neuraxial block or anesthetics agents.
And they are usually volume contracted, they have this volume contracted state, the preeclampsia patient throughout their pregnancy. So it is very, when they just get vasodilated, they will have a drastic fall in the blood pressure, isn't it? Okay.
Yes,
and what about the stress response and all? Are you worried about that?
Yes, ma'am. In laryngoscopy, during laryngoscopy, there is a stress response, which can be increase in heart rate and increase in blood pressure. So to prevent that, we can give injection labetalol pre-induction to maintain the blood pressure within normal range, like 140 to 90 to 150 to 90 millimeter of mercury. And we can give injection Maxelf also 2 to 4 gram IV before the induction, and Xylocard 1.5 milligram per kg can also be given.
Also, another thing you would like to always avoid is, because this patient is already in failure, what is the problem which can happen? Patient can become hypoxic, isn't it?
The pregnancy.
Yeah. Go on, please.
Yeah. In pregnancy, the FRC is low, and
Yes.
this patient was in heart failure and she had developed pulmonary edema. So she may be in the cardiopulmonary, her cardiopulmonary reserve is low. So we should avoid
There will be
hypoxia
a very quick hypoxia in these patients, right? And that can be detrimental, isn't it? Okay, so you are into giving the general anesthesia. So what are your choice of drugs you will be using?
For general anesthesia, for induction agents as well as maintenance also, the agents which has like minimal cardiodepressant effect should be used in case of induction and maintenance in case of general anesthesia. Also, yes, ma'am.
You had used what induction agent?
We had used injection etomidate, which is a more
Right.
cardiostable, and injection fentanyl.
Right. And I mean, during this course, do you want to, avoid using certain drugs? And what are they?
So blood pressure and heart rate should be kept normal. So agents that are causing tachycardia should be avoided, like injection glycopyrrolate, or agents that are causing tachycardia also should be avoided, like injection ketamine also.
Yeah. And during when the child is being delivered out, so we are giving oxytocin. So anything we want to avoid at that point of time?
Yes, ma'am. Methergine should be avoided in case of pre-eclampsia patient. This patient should be avoided causes acute hypertension.
Right. And so if there is by chance there is an increased bleeding intraoperatively, so what will you plan or what will you do immediately?
Immediately 100% oxygen with fluid resuscitation, and if blood products are available, then they should be transfused.
Right.
And accordingly, vitals managed.
Right. Okay. And what are the problems apart from this bleeding and all? What are the problems you are anticipating throughout the course? At what levels, what problem you will face, and what are you prepared with?
So primarily starting from the pre-medications, I will give aspiration prophylaxis, as these patients, particularly pregnant patients, are considered food stomach, and in the form of H2 blockers and also injection metoclopramide. And also during these, again, we have discussed that these patients are prone to hypoxia. So 100% pre-oxygenation with 100% oxygen should be there for at least 3 minutes. And also rapid sequence induction should be done with the induction agents and injection schooling. And stress response of laryngoscopy should be prevented before after in induction we should give pre-induction, like we discussed that we can give injection labetalol and Maxaphil.
So at
Any
what
other
junctures
point
you
of
are
time, any other point of time you expect this kind of response like tachycardia can occur apart from laryngoscopy and intubation?
Yes, if in case of when incision is given, and also at the time of delivery when there is a auto transfusion of blood back in the maternal circulation, and that may precipitate, that increases cardiac output up to 80%, and it may precipitate heart failure also. And other than that, extubation.
Any other you can think of? We tend to give, less inhalational agent, thinking about PPH.
Yes, patient may have awareness intraoperatively, and also if patient is feeling any pain, so analgesia, adequate analgesia should be given.
Right. Suppose you are through during this CS, and suddenly patient develops certain VPCs, sudden run of VPCs on the ECG. What are you likely to think, and what you should be doing at that point of time? What treatment can you give?
Firstly, we should rule out cause of VPCs. If patient has any pain, so adequate anesthesia should be given, or repetition of anesthesia should be given. Then if a patient has lighter pain of anesthesia, patient is aware, then we can deeper the pain of anesthesia with inhalation agent or IV agents can also be given. Benzodiazepine side injection, midazolam can also be given. And if there is ongoing blood loss, that may also precipitate VPCs, along with should monitor other parameter like blood pressure. The hypotension may be there in case of blood loss. So it should be corrected with again IV fluids and blood products if they are available.
Right. So all throughout you are worried about one thing is whether there is a hemodynamic alterations or there is a incidence of failure that can happen. And more so in the post-operative, you would like to continue to give a good post-op analgesia also to the patient. So IV you have said. Anything else you can do?
Intraoperatively, we can give USG guided blocks like bilateral transverse abdominal spring block. And we had decided that this patient will be kept on mechanical ventilation post-operatively. So she was given injection fentanyl 20 microgram per hour, and that also works as an analgesia.
Suppose your patient did not have much of blood loss and was very smooth, as you said. Would you like to give a trial of extubation of this to this patient, or it will be elective ventilation?
The patient should be electively ventilated, as she was in the acute heart failure like recently.
Correct.
So
you don't want to stress the myocardium further, right? So you will continue to give the thing. Okay. So like you said, your patient had you had to give inotropic support after 6-7 hours, right? So why was there a fall in the blood pressure in this patient?
It may be due to post-operativity bleeding, like postpartum hemorrhage may be there, or the patient, her hemoglobin and platelet count were reduced. So also investigation on the previous day, SGOT was on the higher side. So she may be having HELLP syndrome. And also she had developed fever that day, along with the hypotension and decreasing urine output. So it may be a sepsis, and because of that, she may have developed AKI.
If
Okay,
we
can you
talk
go back
about
to the slides
intraoperative,
wherever where we were, in the sequence of events. So it will be helpful for the other people also. Like say a patient was somewhere day 3, right? So go back to those slides and go ahead from there.
and I would again like to ask, if we go back to intraoperative management, what kind of monitoring will you prefer for this patient intraoperatively?
For starting with the basics of monitoring, that is blood pressure monitoring, pulse oximeter monitoring, along with the heart rate and oxygen saturation, and temperature monitoring, also ECG monitoring, and ETCO2 monitoring. Further than that, if it is required, then intra-arterial blood pressure monitoring, that is invasive monitoring, and central venous pressure monitoring can also be done.
How does this CVP monitoring help you?
Central venous pressure monitoring can help in guiding of the fluid management.
How? I mean, what will you what conclusions will you draw if you are going to give fluid to this patient? And if at all you want to give, see, on one hand, you are talking about a low cardiac output, right? And the cardiac function is so poor. So how will you, manage or balance this fluid to the patient?
If fluid challenge or fluid is to be given, then after, if we are giving fluid, then if there is an increase in central venous pressure of 2 mmHg from the baseline, then that means the patient is responsive to fluid, and we can give fluid therapy to this patient. We can increase the IV fluids to the of this patient.
No, if the CVP rises after giving fluid, you think patient is fluid responsive or patient is fluid overloaded? So you have given some fluid, so CVP is rising up. and it is rising tremendously, more than 2, more than 3. So that time it is
means
indicative that patient is overloaded, right?
Yes, ma'am.
And if the CVP remains the same, then you can infuse some more, fluids to this patient, right?
Yes,
So
ma'am.
anything else apart from CVP monitoring you can do? Something non-invasive, maybe in the post-operative period, which will help you guide the fluid therapy.
In post-operative period, we can do the ultrasound guided IVC. You can check ultrasound guided IVC collapsibility. If it is more than 50% collapsible, then patient is underhydrated. We can give fluids.
Right. So, I think probably you have done also in echo, the IVC collapsibility was seen. So
Yes,
every
ma'am.
time you gave the fluids, was there a response to that? You were able to
ma'am.
get a response, isn't it?
Yes, please.
Okay. So, and you had done a repeat ultrasound, abdominal ultrasound. So why, on, I think, day 3 or something. So why did you do it and what were you expecting?
Ultrasound, she had a visible increase in the abdominal girth, and also her hemoglobin and platelet count was reduced. So to rule out any intra-abdominal bleeding, we had done the ultrasound. And also her albumin count was on the lower side, and with the increasing girth, we also wanted to check if she is developing any ascites or not.
So what was the findings on the ultrasound?
There was some free fluid dotted in the ultrasound.
So maybe it was ascites or blood, right?
Yes.
Okay. So basically, what kind of post-operative complications are you anticipating at this point of time? Say patient is you have kept it in the post-operative and elective ventilation. So what all complications can you expect in these patients?
She may develop, like we had discussed, she may develop postpartum hemorrhage, it is
One is
bleeding.
bleeding, yeah.
Yes, she may have sepsis, like puerperal sepsis might be there, and within immediate post-op period. And so because of there may be because of that, and she may have hypotension and ultimately hypoperfusion of kidneys and decrease in urine output, and she may precipitate acute renal failure. And
Anything else you expect in these patients? They are prone to some hypercoagulability states, right?
Yes, ma'am.
So what can you
there
expect?
may be thromboembolytic event in this patient also, like pulmonary embolism.
Why
So
so?
Yes, ma'am.
Why you expect pulmonary thromboembolism in such patients?
The patient has dilated cardiomyopathy, so the left ventricular is dilated, and there might be and ejection fraction is low, so there might be some stasis of blood in the ventricular cavity, which can cause formation of thrombus.
Not
Which
only
may-
LV, all 3 chambers were dilated.
Yes.
So yes, there is stasis of blood.
And
Any
you
other
were
complications related to cardiac function? This patient has dilated cardiomyopathy.
Yes, ma'am. She may develop she may develop arrhythmias also, atrial fibrillation or ventricular tachycardia.
and that happens because of what reason? Like what is happening in the myocardium at the cellular level?
The myocytes are apoptosis, so myocardial death is there, and there may be electrolyte imbalance at the level of cellular level.
And myocardial scarring, there is scarring
Yes.
of the tissues in
Yes,
the
ma'am.
dilated myocardium, right? And so you were supplementing electrolytes also, right? All throughout. Sometimes you were giving calcium, and so like why is it important to supplement and keep them in the normal level? And how much supplementation did you have to give?
So her starting from the sodium, it was on the increasing trend. So hypernatremia in these patients where there is generalized edema, there may be mild diffuse cerebral edema also in preeclampsia, and hypernatremia also, which can precipitate the eclampsia seizure episode in this patient. So it should be corrected, and plus hyperkalemia and hypokalemia, which has the effect on the direct effect on the myocardium. So it should be corrected. Also, hypomagnesemia and hypocalcemia, along with hypercalcemia. which has also membrane stabilizing effect, the calcium and magnesium. So they should be in the normal range.
And potassium has a very low safety index, so it has to be kept very well within the normal range. And we are giving diuretics also. Don't forget that. We
Yes, ma'am.
infusing constantly a BD or something like that we were giving. Right. Okay. Now, in your course of the stay in the post-operative period, you said patient, was doing well, kept off the BiPAP and was shifted onto the oxygen. So what had happened later on? Patient had arrested. You had mentioned, right? So what
Yes, ma'am.
exactly had happened, and what were you thinking? Okay, what could have gone wrong at that point of time?
So she had a tachyarrhythmia previous to the sudden collapse. It can be a complication of dilated cardiomyopathy, as the myocardium is already sensitive, and because of electrolyte imbalance in which her potassium level was somewhat high and her calcium and magnesium level somewhat low. So these patients are already sensitive, have a sensitive myocardium. So normal electrolyte imbalance may precipitate the arrhythmia in this patient. And then she might have gone to the as acute left ventricular failure. And she
Yes,
may have
the patient
developed a
did.
pulmonary embolism also.
Yeah, so she had crepes also, right? Crepitation all over the chest.
Patients.
So fine. So what was the course like after this arrest? That a patient had an arrest and then patient was revived. The patient was intubated and kept again, and there was again an episode of arrhythmia within few hours. And then after that, how her course was? Well, like what all she was started on? Was she started on antiarrhythmics, and was she doing well, or there was some problem in the ECGs and all that?
Yes, because of arrhythmia, after the second collapse, she was given she had developed intermittent arrhythmias also. So she was given injection amiodarone 100 milligram at twice daily basis, and also her blood pressure was after the second collapse, it was on the lower side, for which she was given inotropic support, but which was tapered off in 12 hours. After that, her blood pressure was remained on the higher side. So when we were giving injection labetalol, she precipitated the arrhythmias. So it was kept on
So
hold.
what information you get by this? What was happening? See, you said patient improved also very quickly, but there was whatever you were doing to the patient at that point of time, the patient used to start developing arrhythmias, right? So what information you get from that?
Patient was just revived, so her myocardium was sensitive to any of the external stimuli that we were giving. So for that, she developed arrhythmia, whatever we are giving.
And probably it was a reversible, something had happened which was reversible, and patient improved also after that, right? So at present, what is patient receiving now?
She was on antihypertensive calcium channel blocker, that is tablet amlodipine 5 milligram twice daily doses, and she is given diuretics like tablet furosemide and tablet aldactone for treatment, and as anticoagulation, tablet aspirin is started on the 75 milligram OD basis.
And anything beta blockers also, no? Patient is receiving,
Yes,
right?
metoprolol is started. Yes, beta blocker.
So how does beta blockers help in these patients?
So beta blockers should actually not given should be not given in acute heart failure when there is ejection fraction is less than 40%. She had improvement in the ejection fraction. Her ejection rate is 45 to 50% now, and she has come out of the failure. And so beta blocker should be given, which helps in the cardiac remodeling also, and it improves the cardiac contractility also.
Yeah, and only thing is keep in mind that it has to be avoided in acute failure. Only when patient is recovered from that, you can continue and start that. So generally, what is the outcome of these patients of dilated cardiomyopathy? Like, do you get a good recovery, or do you have prolonged problems in this patient? And how do they get discharged to home?
These patients
So we are now
are
talking about critical care. We are trying to get the patient out, and yeah, continue.
Ma'am, the postpartum cardiomyopathy is usually reversible because the cause is ultimately pregnancy. So after the effects are removed of pregnancy and the hormonal levels are subsided, the cardiac function returns to normal in more than 50% of the patient. And the mortality is around 20% after 1 year of diagnosis.
Yeah, so some of them will be having residual cardiomyopathy, and those patients may go into failure again and again, repeated failure, and many a times these patients may even require home therapy in form of BiPAP, and patient may have been stabilized on the drugs, but home therapy in form of BiPAP may be required, isn't it?
Yes, ma'am.
Any vitamin deficiency associated with dilated cardiomyopathy?
The thiamine deficiency, vitamin D deficiency also, and in case of trace element, selenium deficiency can be associated with the dilated cardiomyopathy.
Absolutely. What are certain advanced now I would like to ask you, like, are there any advanced therapies or management for these patients whose ejection fraction does not improve, or they are gone into a kind of a chronic phase?
So even after the continuous pharmacotherapy, if patient ejection fraction is not improved and her NYHA grading is also remaining on the 3-4 side and she is symptomatic, then they approximately 10% of the patient requires the cardiac transplantation. And before that, some patients also require mechanical ventricular support like intra-aortic balloon pump and left ventricular assist devices.
Right. Can you explain the role of neurohumoral blocker in management of PPCM?
Like we have talked about that pathogenesis. In pathogenesis, prolactin may cause the left ventricular dysfunction. So to reduce the prolactin level, patient may be advised for cessation of breastfeeding, and also she may be given bromocriptine, which decreases which inhibits the prolactin release.
Yeah, and like we are seeing very commonly this kind of condition, isn't it? Like especially patients who are taking IVF treatment and they have a prolonged hormonal therapy going on. So these patients would be sometimes prone. So maybe in the history you should also ask whether they have been subjected to any hormone therapy earlier. Any other management, any advanced therapies for increasing contractility of the cardiac muscle? Do you know that?
Newer drugs like omecamtiv can be used.
Yeah, some myosin modulators. So these are all at the
Yes.
experimental levels, but yeah, they do improve. They can be given later on. See, basically, so I think you have kind of managed this case pretty well. Can you kind of summarize the whole thing regarding the management and finally at what point of time we are now with the patient?
So, to summarize the postpartum cardiomyopathy, it is an important cause of maternal mortality and morbidity. And like up to 20% of the patients have mortality in these post cardiomyopathy. And timely diagnosis and treatment is necessary to prevent maternal mortality and sudden cardiac death. So our goals are to reduce preload as well as afterload, for which we can use antihypertensive to reduce hypertension, to prevent fluid overload and also pulmonary edema, and ultimately to prevent the conversion of preeclampsia to eclampsia also, and prevent the complications, and if present, to treat these complications like ventricular arrhythmia and atrial fibrillation, and also any thromboembolic event. And termination of pregnancy is considered if fetal outcome, according to the fetal outcome and stability of the mother. And overall prevention should be there in case of genetic counseling can be done, as there are genes involved in the pathophysiology, or there are genes that are diagnosed that they may cause cardiomyopathy, and family planning should be there in case of patient who are not who have not resolved these cardiomyopathies for subsequent pregnancy.
Yeah, so I mean, either you avoid the pregnancy or have a genetic counseling, or you have some advanced management. So basically, in short, the dilated cardiomyopathy patients can be a big challenge because the pregnancy symptoms are mimicked. Patient having preeclampsia are also prone to DCM, and their symptomatology also overlaps. So it has to be a high index of suspicion right at the point when preeclampsia patient comes in and goes on to failure. Probably, I think early echocardiography can help diagnose or delineate the features of DCM versus the other types of cardiomyopathy or valvular heart disease or ischemic cardiomyopathy. And because these patients do have a very high mortality, even when they recover also, like many of them, more than 50% should be having their ejection fraction coming back to near normal. But they do have say, for example, 1 year mortality is 25%, and it is said another 5 years down the line, their mortality might be on the higher side if the things are not corrected. So it becomes a very important case, and they are all young patients. These are all young patients where we need to do something aggressively. Like the data from mortality due to cardiomyopathy is something even high as 25 to 70%, whereas patient only presenting with preeclampsia and failure, they would have something mortality quite lesser than this. So it is a nearly 10 to 20 times the mortality with DCM. So these patients do become important for in the diagnostic point of view and for the further management, and later on also, because these patients do have a very roller coaster eventful happening like we had in our patient. That patient can throw up arrhythmias at any point of time, patient can go into failure at any point of time, and patient be going in and out, and maybe will require chronic therapy in terms of BiPAP also. So I think that sums up about the case, Dr. Nishant. We can start taking the questions also from the chat box.
Yes, ma'am. Thank you, ma'am. There are a few questions from the chat box. Dr. Raju wants to know what will be choice of anesthesia if same patient present for elective cesarean section, GA or epidural, considering normal vitals and normal coagulation profile.
If a patient is posted for elective surgery, we can go for epidural anesthesia also, which have a advantage that there is a gradual decrease in gradual decrease in blood pressure. So gradual hypotension there is there, which can be tackled with the inotropic support or fluid therapy.
But eye
So,
has to be kept
ejection
on the
fraction-
ejection fraction. Yes, yes, absolutely. Like we need to know about the ejection fraction first. If it is pretty low, say less than 20%, then these patients will be definitely prone to severe hypotension, even with epidural. Ultimately, we do have a sympathetic blockade, so it is better in those cases, then we can just selectively go for general anesthesia.
Thank you, ma'am. Our next question is Dr. Mohan sir wants to know what are safe drugs and inhalational agents for GA in these patients, and is carboprost or prostadine safe in these patients?
Safer drugs are, as we have discussed, that which have lower side effects on the cardiac function. So, which are less cardiodepressants. Like for induction, we can use injection fentanyl and injection etomidate also. For maintenance, sevoflurane is used, which has for
Least cardiac effect.
yes.
Yes, our next question, Dr. Muthukumar sir wants to know monitoring PPV or SPV, which will be more dynamic over for fluid management than CVP.
We can do pulse pressure variation also, but somehow we don't have those advanced monitoring facilities. So the variation can be seen in the pulse pressure. If it is going more than 13%, then there can, we can give fluids and see. But this is something, bare minimum would be at least a CVP measurement. So many a times we even do not have the invasive monitor for that. So it becomes very difficult to go in for other advanced cardiac monitors. But yes, it can be helpful, definitely.
Yes. Dr. Lalinkima wants to know why amiodarone was given intermittently instead of infusion in this patient.
Amiodarone.
Sir, ma'am, the patient had developed arrhythmia, which were like episodic, they were not continuous. She had only 2 to 3 episodes of arrhythmias also. So as a preventive therapy, we had given amiodarone.
Okay.
There was no hemodynamic instability along with that, or it was for a very brief period. So we had started the amiodarone then, and later on, I think there was some QT prolongation also happening along with electrolyte imbalance, and that is the time when it was actually stopped.
Okay, ma'am. Thank you. Dr. Chiragi wants to know if even if patient or fetus are stable, shall we wait for progression of labor, or there should be immediate termination of the pregnancy should be considered? And also, what is the reason for increasing cases of dilated cardiomyopathy in pregnancy nowadays?
So this basically, I mean, you better to go and terminate the pregnancy because the inciting factor is the fetus itself, and go for a cesarean section, because it is said even if it's severe preeclampsia, if there is a added organ failure, then it becomes an indication. But I think in this particular case, since the patient was kept on BiPAP, the vitals had stabilized, and this patient being twins, the trial was given. More so, as discussed with the obstetrician, they had also consulted the cardiologist at that point of time. And cardiologist probably had said that, see, CS has got its own demerits also, that there is a more blood loss, the drugs that we give cause more vasodilatation. So, sort of weighing the benefit to risk ratio, the normal, going for a normal delivery was, done, keeping in mind that this patient can be converted to cesarean section at any point of time, and the readiness was there for this. And I think there was another question to it, right? One is whether normal delivery and anything else. Did he ask?
Dr. Mohan sir has asked what should be the mode of ventilation if ventilation is required, ma'am. Next question.
Okay, Zalak, can you answer
Jhalak, would you answer this?
Yes, if post-operative ventilation is required, then on the first post-operative day, we can keep the patient on control mode of ventilation under sedation and also paralysis. And after that, depending on the vitals and investigation, patient can be weaned off.
Yeah, so easier said than done, actually. So generally, the first post-op day, we want the patient to be completely sedated and proper analgesia to be given so that the patient recovers from the acute phase of the cesarean section or the hemodynamic instability that has occurred intra-op. Okay. So, I mean, these patients, if they become totally awake, then they become rowdy. So probably the initially few hours we can keep the patient paralyzed. But it is said that if patient is well taken care with the sedation and analgesia, then you can actually stop the paralytic agents, because paralytic agents actually hamper the recovery. They make the secretions retained inside and can give rise to VAP later on. So ultimately, whatever we do, it has to be a slow phase. See, remember, when we ask patient to start breathing after a post-op elective ventilation, it is like running a race against time. So the heart is going to get worked up like anything, and patient will again be prone to failure. And these patients specifically with a low ejection fraction are prone to failure at this weaning period of time. So it has to be done in a very staged manner. And later on, we can give the SIMV and maybe a CPAP trial only after seeing what is happening to her respiratory rate.
Okay, ma'am. Dr. Sanjit Ravi wants to know how long should patient be abstained from breastfeeding if multiple doses of amiodarone is given?
I think patient can be, I mean, I would not answer directly. I would definitely consult the cardiologist because the half-life of amiodarone is a pretty long, I think it is around 10 to 12 hours if I'm not mistaken. So maybe if the patient is weaned off from amiodarone, then we can restart the feeding after that. This patient, we basically had a QT prolongation. Initially, we were trying to keep antiarrhythmic agents because her myocardium was totally irritable. Any simple intervention like giving her positioning or waking up, and the second time she used to throw in ventricular arrhythmia. So, but then we had to stop the amiodarone because the patient developed QT prolongation also. So that till then, after that, we started the breastfeeding. We expressed the milk, and then even later on, we started giving the baby to the mother also.
Thank you, ma'am. Our next question, Dr. Vikas sir is asking, is there any role of thyroid function test?
If patient is having any like symptoms of hypothyroidism or hyperthyroidism, like weight gain, acute weight gain, or there is a bradycardia which is remaining, or then patient then thyroid function test can be advised.
Yeah, but another just a caveat to that is many a times your thyroid functions may be actually deranged also in critical care, critical illness. So even if we do get it done, we might have to repeat it again when patient is normalized to establish whether there is a hypothyroidism or not.
Thank you, ma'am. Our next question, Dr. Muthu Kumar sir wants to know which inotropes were used for this patient post-operatively.
She was relatively vitally stable throughout, but for a brief period of time when she had hypotension, we used injection noradrenaline for inotropic support.
So, I mean, the rationale behind that, Jalak, can you mention which would be preferable?
We have to keep in mind that there should not be, along with increasing blood pressure, heart rate will increasing every vasopressor that we are using. So, which has minimal effect on heart rate, we can use that vasopressor. So, which will not ultimately precipitate any arrhythmia.
Right.
Okay. Thank you, Jalak.
Also, there is one suggestion from Dr. Abhishek that graded epidural is good choice if hemodynamics are dealt properly.
Yeah.
And goal
Yes.
is to preserve inotropy, avoid sudden changes in SVR, and maintaining optimal preload.
Yeah, absolutely. I think that is a good suggestion, and in fact, we do that, especially patients with preeclampsia and whose BP is well controlled. Maybe in those patients we can give the epidural, but this patient having a very low ejection fraction, it was just 25%. So, I mean that, and plus obviously we had this element of failure coming in, so there was no way we could have given an epidural. We would have risked the fall in the blood pressure much more than the advantage it gave. Although it can be used for a good post-op analgesia for later on, so as to avoid the stress responses due to pain and all. And it also helps in weaning if patient's pain is taken well control of. But particularly this patient, we were not very comfortable because of the way she was going, and we wanted to avoid any sort of hemodynamic instability. And also later on, this patient did have low platelets, although the first reading was normal, but we were having decreasing platelets later on. So probably then we have to avoid giving epidural.
And Dr. Muthukumar is saying that Mildred will be preferable with NORAD.
Yeah, so it is a cardiolator, basically, inolator type of therapy, yes. But I mean, it is probably the choice from the cardiologist. We were in, well in conversation with the physician and the cardiologist. So particularly, I mean, that had taken care initially. So, but yes, inolators can be given. Thank you for the suggestion. Absolutely great. Any more questions which are coming on?
I think we have
No,
covered almost all the questions.
Yes.
Just
Yes, ma'am.
Pranita,
Yes, ma'am.
you just check if anybody wants to speak from the
No, ma'am.
audience. Anybody has raised the hands? Okay.
No, ma'am. Not.
Okay. So I have a question for Dr. Jhalak.
Yes, ma'am.
Your diagnosis is peripartum cardiomyopathy, right?
Yes, ma'am.
So I have got two different diagnoses. One is acute heart failure due to PIH. And the second is Takotsubo cardiomyopathy.
Yes.
So how will you defend your diagnosis of dilated peripartum cardiomyopathy in this case? First one is acute left ventricular failure due to hypertension in a case of PIH, right? Your case had PIH.
Yes, ma'am.
So tell me that how could it be, how could it not be acute left ventricular? How could it not be acute heart failure?
A patient presented with the features of acute heart failure, with the like dyspnea.
What features? What were the positive points for acute heart failure?
She had sudden onset of breathlessness, dyspnea was there.
Yeah.
She had pulmonary capitations, pedal edema was there.
Okay.
And she had developed hypoxia also.
Yes. She had low saturation.
Yes, ma'am.
Correct. So was there pulmonary edema?
Yes, ma'am. On auscultation, bilateral capitations were present.
Crepitations were there.
Yes,
So
ma'am.
that time, if you had done a lung ultrasound, probably you could have found out that there is increased extravascular water in the lungs.
Yes,
So what is the role of lung ultrasound in this case preoperatively? Or maybe just like that in the obstetric critical care unit? In the diagnosis.
As ma'am, you said that we can check for the pulmonary edema if it is present, and to check if the congestion is there or not.
You can see the B pattern in the lungs, and you can find out the echo-comet score and find out, okay, whether there's pulmonary edema. Okay, then anything else? Then how is it that it is cardiomyopathy then? That means, that means you have to tell the positive points in favor of peripartum cardiomyopathy.
So basically, in definition, it is said that peripartum, that means should be cardiomyopathy is decrease in acute and severe decrease in left ventricular function. Like ejection fraction is less than or equal to 45%, and which was present in this patient also.
There are some cardiomyopathies with a preserved ejection fraction also, right? Okay, then.
And in case of peripartum, the patient presented during the gestational period and also in the last trimester. And patient may present up to the 5 months after delivery also.
Yes.
Yeah, and I think the dilated chambers supports your diagnosis, isn't it? You had dilatation of the chambers. That supports your diagnosis, isn't it?
Yes, ma'am.
Dilated chambers and a low ejection fraction of only 20%.
Yes.
With the regurgitation, no? There is MR and some aortic regurgitation and some valvular regurg is also there. Correct.
Zalak, you told the crepitations, but always have to differentiate between the type of crepitations in these type of cases. I think you may be having some pulmonary pathology. You may have some coarse crepitation with the pneumonitis, inflammation of the alveoli and all those things. The sounds are different. With the left ventricular failure, you will get a very fine crepitation.
Fine creps. Yes, sir.
Okay, so those word has to be mentioned during the viva.
Yeah.
Fine and coarse, there are different words. Very well differentiating between the cardiac cause and the pulmonary causes also.
Yes, sir. Definitely.
And Jhalak,
yes, ma'am.
The next one is the Takotsubo cardiomyopathy.
Yes, it's basically predictor risk factors are or the prone age prone population is menopausal, post-menopausal women, not the pregnant female.
No. You can get it in pregnancy also. You won't
Yes,
have
ma'am.
a postmenopausal woman with that.
We see
You
more
can
in
see Takotsubo cardiomyopathy is also seen in pregnancy. You can get a
Yes,
case for cesarean section also.
yes, ma'am.
So what is it? Induced by stress, right?
Stress, yes.
So then how can you not say that this case is a Takotsubo cardiomyopathy?
On the basis of findings of 2D echo also.
So what should be there? What should be there on 2D echo?
The chambers are also dilated in that,
Chambers
but
are dilated. That is so dilated cardiomyopathy. That is sure. Anything else?
Left ventricular is particularly more prone to the dilatation.
No. This you can tell if you know what is Takotsubo cardiomyopathy. See, in Takotsubo, what happens is it is due to stress. Okay.
Yes,
and what happens is many a times the patient will complain of chest pain, and there can be ischemic changes on the ECG,
yes,
like ST segment elevation and so on. Your patient's ECG was normal, right?
Yes, ma'am.
You said your patient's ECG was normal.
Yes, ma'am.
So that is one thing. Okay. And Takotsubo, they recover quite early. The prognosis is much better than your patient, what is that? Hypertrophic, your dilated cardiomyopathy. Okay. I just wanted you to think like, why not this? Why not that?
Yes,
you have presented it very well. Very good presentation. Yeah. And could you have estimated the BNP levels, the brain natriuretic peptide levels in this case?
If usually they are elevated in case of cardiomyopathies. So if we did that, it might be elevated.
If the facilities are there, you can do it.
Yes.
Isn't it? Correct. And what about the risk
Dr.
scoring?
Madhuri, just let them tell her, are they specific or what? They are
not very specific,
They
sir.
are just supplementary diagnosis. They are not specific for the diagnosis.
Yes, sir. Yes, not at all. And Jhalak, what about the risk scoring in this case? Suppose you have taken this case for cesarean section. Now, how will you risk the this patient?
So, patient can be risk stratification can be done according to the RCRI, revised cardiac risk index also. According to the all the parameters that are present in there, she can be given the index.
Any other risk score for this thing? Pregnancy, cardiac risk scores? Of course, which may not be very much applicable to this case, but in general, if you have a pregnant patient with heart disease, and you have to risk
scoring name, yes, CAR-PREG and Zahara scoring.
Yes, CAR-PREG and Zahara and WHO. So can you score it here, your patient?
Yeah, she can be scored according to what she had been presented with the all the investigations and clinical condition.
Basically, the failure.
I think in this type of cases where complications are there and unanticipated and anticipated, both components were there in this case. To manage such cases, risk stratification becomes very difficult, and it's only on the clinical evaluation that particular point that you can evaluate. It's very difficult to proactively anticipate all the risk scoring and going for the. Then it would have been very easier. You may not have encountered this case. So this case, I think, such type of cases when they come to your clinical this one scenario, you have to manage. The scoring pattern goes side by side according to the management rather than pre-evaluating it. Then you're going for all the management strategies. So these are the difficulties in such type of cases where the comorbidities are little difficult to predefine and manage accordingly. I think as and when basis, whatever was coming, because life was more important in these type of cases. The human safety, patient safety, I think that is more important what you have done in this case. And it's a real case scenario presentation, and it's very well, appreciated such cases, because these type of cases should be presented and published also in the journals. That's why you get you much acclaim for these type of things.
Yes, absolutely.
Exactly.
Yeah, and because it is very difficult to differentiate at the outset, like what exactly the patient has, because most of them, whether it is severe preeclampsia with failure, whether it is a cardiomyopathy due to ischemia or due to cardiomyopathy due to dilated, they will be presenting in the same manner. And the first and foremost is to, basically try and give the ABCs that we have to do. So after that, yes, and the scoring will definitely help because it is depending on the physical examination, the clinical features, and there is a whole list of things associated with it.
Scoring, ma'am, basically scoring, you can always have a soup for discussion after the case is managed properly. The case is being, because every small minute details have to be given a due consideration while managing these patients. The risk stratification, you can always do the retrospectively also.
Yes.
But I think with the clinical experience of handling so many cases over the years, that's why the role of seniors comes here. The PG students may not be able to handle such cases. That's a fact. In 3 years, you may not be able to handle such cases, but a lot of experience at the professor level, you must have come across many such cases. May not be the same, but similar cases, which can give you cue how to go about managing such cases. Rest is for theoretical discussion and clinical examination and theoretical examination in the finals also.
Yes. And I think there is one element of, this IVF therapy, which probably is also giving rise to a lot of, there are kind of increased number of cases as discussed with the obstetrician. They are also finding the increased incidence of DCM in pregnancy. And also, mothers with cardiac factors, cardiac diseases, the rate of pregnancy is increasing in them. So probably there is a increase incidence in that particular keeping that in mind. So these kind of presentations are there more with us also. We are also finding this increased number of patients coming with this conditions.
Yeah, that's basically another specialty, the obstetrics, where you can go for the genetic studies with such type of cases, genetic studies and other factors which are, I think, very those which are not visible to you. For those studies, you have to be at least in a good collaboration with the other specialty to go for such studies before you can really say that these patients are coming later on with the more complicated scenario. So definitely you are right here. We have encountered certain cases where we have seen in the case reports when you go through the journals, you will come across this with the history of the IVF for artificial insemination also even, not just IVF.
Yes.
Where you will find that the cardiac involvement was there, uh, which I think the incidence has to be correlated directly with the procedure duration, the procedure, when was the procedure done, and how many times the procedure was done. That is also there. So many things are there which, were hidden. So very difficult to evaluate at the moment. But again, I think Zalak being by the side of the seniors in managing this case, it's a good learning experience for a PG student because every PG student should have seen such type of difficult cases. Tomorrow they are going to handle these cases independently, whether they are having some bond or going in the periphery to manage such cases or in the institution or in the corporate hospital or the freelancers. I think to manage such cases immediately for emergency cesarean section on the table, it's very difficult. Unless until you know something, you must have seen those things, or you may be playing with the life of the patient, two lives at the same time. So this is very important in the presence of senior. If you are managing such cases, it gives you a lot of confidence and experience for the future. I think Dr. Pranita and Dr. Vishali, you can you can invite the people who can want to give their comments or want to share their experiences because Zalak has done wonderfully well under the guidance of Dr. Neeta and Dr. Dharatana. So that is already gone. So you should invite people for their expert comments in these type of cases.
Yes. Thank you, sir. Thank you, sir.
We'll have to unmute, I think.
Anyone can unmute themselves now.
So just to continue on what Madhuri ma'am had mentioned, the use of ultrasound, the lung ultrasound in these cases is becoming increasingly important, and not just these dilated cardiomyopathies, also the stenotic heart diseases in which administration needs to be monitored. There the focus and the lung ultrasound is very useful. as we have also seen in some cases that we have done. It was a very nice presentation, Zalak. Do you have any MCQs for the audience?
Yes, sir, I have.
So,
Dr. Mohan Pathak is there.
Yes.
Hello.
Yes, sir.
Hello.
Dr. Mohan, please.
Sir, I think if you think slightest indication of some breathing problem or some irregularity with the heart, they can go for a 2D echo, which will help X-rays and 2D echo during ANC, because sometimes they come suddenly with the problem with fetal distress at the last moment in the peripheral practice. It is very difficult to tackle, and really it's like playing with the life of patient, two lives at a time. So simple 2D echo, it can be done frequently during ANC. Will save most of the problems, I think so.
Definitely, sir. Definitely. That's what even I was also trying to say at that time.
Yeah.
Yeah. Yeah, this is a question, no?
Yes, sir. We have MCQ for the audience. Our first MCQ: what is the primary treatment goal for peripartum cardiomyopathy? A. Surgical intervention. B. Hormonal therapy. C. Managing symptoms and supporting heart function. And antibiotic therapy. Your answers are welcome.
I think you tell them how to write. Yeah. The answer is right on the screen.
Yeah, answers are right on the screen.
You have asked a very simple question, actually. You should have written antibiotic therapy and managing symptoms. Then would have a little bit of more of a complicated.
Till now, we have got all the right answers.
Yeah. I think it's right. That you can go for the second question now.
Jalak, second question, please. General treatment of peripartum cardiomyopathy includes all except spironolactone, dopamine, antiarrhythmic drugs, and beta blockers.
No answer? B. Okay. C भी आ गया. A रह गया बस. So this is very interesting, you know.
Okay.
ये आ गया, A भी आ गया.
Okay, A भी आ गया. So I think it is except which we have to, keep our minds on. I mean, basically, we are talking here of general treatment and not the acute treatment of the failure.
Yes.
So when we say general treatment, then diuretics, yes, spironolactone we do give. Antiarrhythmic drugs because they are prone to arrhythmias, so patient would require antiarrhythmics at some point of time if patient is developing. And beta blockers is actually the mainstay of treatment for cardiac remodeling and improving the cardiac output. And dopamine, even if, in fact, they are saying that inotropic agents, if it is required, we do not really give dopamine. You have to give some other drugs which are less arrhythmogenic. So again, dopamine would be in an acute setting, nevertheless. So only when the blood pressure is low. So we would try and avoid that. So, so the answer is B.
Okay, thank you, ma'am.
I hope nobody has any doubts about that.
No, it's cleared. Next, following clinical finding associated favorable prognosis. New York Heart Association grade less than 4, right heart failure, syncope, AV block. Favorable prognosis.
That is a tough one, I guess.
Yeah, it's a good one, actually. It's a good question. Now the answers will be a little slow. B. It's come B. A has also come. I'm waiting for C and D. Yeah, C has come. C. Now, Zalak, can you tell the logic behind the answers? Or
So
your teacher will be telling?
Answer is A, NOHA reading less than 4. As the patient's ejection fraction improves, her cardiac left ventricular contractility improves, the symptoms of heart failure will be decreased.
Why not the
So
rest of the? That is also you
Why
have to
not
tell
the
the
rest?
logics.
Why not the rest? You have to mention that. That is
Why the
more
syncope
important.
is not the answer? That's very important. Tell me now. Why the syncope is not the answer to this question?
hope we will maybe due to hypoperfusion of brain also. So it occurs in the when cardiac output is on the lower side. So it is not it doesn't favor the favorable prognosis.
No, no, no. This is not the right answer. Syncope is a with cardiac dilated. This one myopathy, na? इसका just know the logic. What should be the logic actually? Why not? It's a favorable prognosis. क्यों नहीं होगा इसके साथ? This is important. That's why I told you a difficult question. Answers will be very difficult to evaluate here. One is coarctation. Okay. That can be the co-findings. What else?
Yes.
If it
Yes.
is cardiomyopathy other than dilated, like hypertrophic obstructive cardiomyopathy, then decreases the cardiac output also.
So when does syncope occur? So if there is something going on, see, all the three things which have been mentioned is like there is some permanent damage which has occurred. So if there is a
Yes,
myocardial
that's
scarring,
irreversible
yes,
stage.
yes,
Irreversible.
irreversible. So then you cannot correct it with anything. So you will have a good prognosis only if there is a reversible thing. And NYHA grade 3 is less than 4 means patient is not yet that bad. Right heart failure is established when your back pressure changes have been there. So your right heart fails. So that tells you about the organ involvement, and that becomes an irreversible thing. Syncope also when you are having arrhythmias or permanent myocardial scarring and all. So repeated thing is happening. What can you do more than that except go for a heart transplant? Then AV block is when when you have a AV involvement, say the right heart failure involvement is there. There's a dilatation of the AV ring and there is a block pattern occurring. So again, it is a permanent damage. So these things are permanent. So they will not be able to reverse just by simple therapy.
In spite of
Anything else?
syncope, you should have written multiple episodes of syncope.
Yeah, okay, yes.
Because it's keep on happening. The syncope
Yes,
keeps
yes,
on happening.
absolutely. Repeated.
Repeated. Any other question is there?
Yes, sir. One more is there.
Okay.
What is the long-term prognosis for women with peripartum cardiomyopathy? Complete recovery in all cases, increased risk of heart failure and other complications, no impact on future pregnancies, reduced risk of cardiovascular issues later in life.
There are two answers to this thing. The B is a very common answer. Whenever the word comes complete or reversible something, it's never to be taken. That's okay.
Yeah,
A is
that's to how to answer the MCQ tricks.
Now the C choice is a very, a little bit of tricky choice. No impact on future pregnancies. Impact mean why the effect on pregnancy will occur? It's impact on heart.
Yeah.
Basically. No effect of future pregnancies. Should be like that.
Yeah. But basically, you're trying to avoid the pregnancy in future. That is sort of
Dr. Parna
probably.
Thakkar has raised hand. She should answer. Dr. Parna, you can unmute yourself.
So after the questionnaire, I would like to share my experience.
I think you
One of
were
the
going to
cases.
answer and give the logics. I was anticipating that.
So basically, complete recovery in most of the cases and increased risk of heart failure and other complications in the subsequent pregnancies. So those are the two answers. And I think those are the two answers.
Yeah, it's basically the increased risk of heart failure and other complications. Basically, because these patients, the follow-up is very poor. You require a regular follow-up for these type of cases.
Yes.
And
Yes.
invariably, what happens in our society, the pregnancy sometimes go unplanned and people don't care about their own health. So those things are
Yes.
very much neglected things. So whenever you have a pregnancy again, definitely it is going to invite the ire. The cardiac tissue is already compromised tissue. It is not in a complete recovery stage. It can never recover. Damage done to the myocardium, this one,
Will
striatal
never.
muscle. Striatal muscle, it is irreversible damage occurs during the cardiomyopathy. Because one stretch, it remains just like a rubber. Na? When you stretch the rubber, it's remain in a stretch state. It's just like happening with the cardiac tissue
With the
also.
cardiac tissue.
So that's the reason it's a compromised cardiac status. It will never come to the complete recovery, and the heart failure will always remain.
Yeah.
So answer is a
But
B to this question.
But like
cardiac function wise, they many a times improve. So that's what I had noticed in the
That
case which I dealt with.
that improvements only when the pregnancy is
Yes,
when
after
pregnancy gets
4
delivery.
to 8 weeks.
But
Yes,
but the thing is the risk in the future life. That's more important.
yes,
That recovers.
yeah.
The function recovers
yes,
to some extent after the delivery. But
yes,
again, when they present the
that's
pregnancy,
right.
then it is going to happen. Problem is
Yes, yes,
Mm.
yes. So, sir, can I share the experience?
yeah, please.
Okay. So a few years back, I got a call for labor analgesia, and absolutely a normal patient. Normal in the sense, otherwise her pregnancy was not complicated, and she didn't have any symptoms except some epigastric discomfort, which was there since last 2 3 weeks. That's what she told me on pre-operative evaluation. Now, she was a case of seizure disorder, and she had taken anticonvulsants for almost about 10 years. And then she had stopped for more than 12 years, and she was absolutely fine. I gave her labor epidural, and she tolerated the procedure well, the procedure part of it. And as soon as I gave 4 5 cc, like a test dose of the 0.1% sensorcaine with 2 mics per cc of fentanyl, she had sudden hypotension. Her BP dropped to around 60 and she became semi conscious. Then later on, she stopped breathing and she started developing arrhythmias. Immediately, we took her up for cesarean section. I intubated her, and C section was carried out under general anesthesia. And I also had to start NORAD for her. Then, post operatively, this was middle of the night, so she was ventilated. Next day, she was extubated. Her 2D echo, bedside 2D echo was done, and her EF was found to be 30%. Then she could be extubated, and all the treatment for peripartum cardiomyopathy was started. And after 6 weeks, she completely recovered. Her cardiac function came back to normal. And this case was even published in one of the international journals. So, like, it just came as a surprise. I was not prepared for anything. It was just like a normal labor epidural call. But from that time onwards, of course, I used to keep things for airway management always ready. But now I doubly make sure that oxygen is there. If you are giving in labor suit, then make sure that things for ventilation are handy. So it was a great learning for me. Thank you.
That's true because in the peripheries, the resources are always minimal. You have to check over those facts because the anesthesiologist is the sole person who can think of all these catastrophes. So I think we are in the state where we can really play a good role in the safety of patient everywhere, even in the resource challenge scenarios, especially in the peripheries. Definitely. Anybody else before I think anybody says we at least time for uh, felicitation of our faculty today. Is my screen visible now?
Yes,
Yes.
sir.
Yes, sir.
So it's really a very commendable class, a difficult case, handled very meticulously. Uh, we congratulate the team of Dr. Neeta Bose, Madam, and Dr. Dhara. So,
Thank you, sir. I would like to take the opportunity for thanking you heartily. This has been a great learning experience for me and my team to be here on the national platform. And this discussion has provoked a lot of thought-provoking, statements, and probably this is the way we should go about it. And I'm very, very happy that our PGs and many of the anesthesiologists from the periphery are benefiting absolutely greatly, because I've heard the other lectures also, And I think, there is no end of questions and there is no end of learning if we go in this kind of a meticulous manner, because we dwell on a topic for such a long time, and it becomes thorough for the PG who presents as well as the PGs who are listening. They become really prepared with this topic. So I think this has to be absolutely encouraged. And thanks once again for letting us be here. And would be like to be part of this platform again and again as a listener also, because I do go about these lectures. These are very, very useful, and I encourage my PGs also to go through them. Thank you, sir, very much.
Thank you, ma'am.
Yes, definitely, sir. We really appreciate. Thank you very much.
Thank you, ma'am. But it's not me. It's ISA National. I'm the just face of the ISA National, and I don't give the compliments personally to me. It's the entire ISA National plus our class coordinators, Dr. Madhuri, Dr. Nishant, and our now the every time the screen coordinators, just like today, Dr. Pranita and
Dr.
Dr.
Vaishali
Vishali.
and Dr. Pranita also, they have been really helping us in the backstage, and because many a times the technical problems do come in and we really face a issue. So thank you very much, Dr. Madhuri, Dr. Nishant, and yourself, sir, and Pranita.
You will see all the people from all parts of the country come for this class. All parts of the country you will be seeing here. So that's the beauty of these classes. So thank you, ma'am. This is a small felicitation from our side for your dedicated involvement.
Thank you, sir. Thank you.
मैडम धारातना, आपका भी उतना ही शुक्रिया जितना आपने डॉक्टर नीता का किया, because both of you prepared Zalak very well, and she was very confident, and we liked her confidence, and it gives what you called confidence to other PG students also who must have been watching these classes. So Zalak, you are being aptly awarded for this certificate. Just consider it as a pre-final pass certificate for you, where you will be appearing for the final. Show this certificate to the examiner that I've already appeared in the pre-final. Okay,
Absolutely.
And Dr. Vishali and Dr. Pranita, thank you very much, because you both did a wonderful job today. And
thank you, sir. Thank you so much. Thank you, sir, for giving me an opportunity to be here today. And I thank all our senior, I thank you, sir, especially for giving me this opportunity. And I thank ISA for this wonderful initiation of this online PG classes. It helps not only PG students, but every practicing anesthetist. So we keep getting updated in our topics every time we attend to these classes. Thank you, Neeta ma'am, for your wonderful for wonderful guidance. Thank you so much, Dhara ma'am. I thank you, Madhuri ma'am and Nishant sir, for helping us how to go about it and helping with everything. And thank you, Jalak, for your wonderful presentation. I once again thank you, sir. And I thanks all audience for attending today.
Yeah, that's great. And I think whosoever is watching these classes, they should spread the good word about it, because even if they don't get time to see in live telecast, they can always go to the YouTube ISNHQ, YouTube at ISNHQ, and they can see the recording of this class. And it will be very helpful for the preparation for your final examination, because majority of the questions being asked in these classes are going to be covered in your final Viva. So I think almost every topics will be getting covered in another 3 or 4 months, whichever you will be getting in your examination. So good for every PG. So anybody want to say something for a final before we close this class? I think the audience knows this is 8:30, because usually we close at 8:30. So Dr. Madhuri, you want to say now again?
Madam.
Dr. Madhuri, did you raise your hand?
Yeah, I did raise, and then I lowered it also. No, I just wanted to say that that is why now the concept of the pregnancy heart team has come up, where they include the cardiologist, the anesthesiologist, the intensivist, and the obstetrician and the endocrinologist. All are involved in starting from conception counseling to pregnancy monitoring to the postnatal monitoring and treatment and management. I just wanted to add that concept of the pregnancy heart team, that is known as the PHT. Just wanted to add that new concept. And it's just in theory. I don't know, like where
These
it's.
concepts will be there because in the coming days, with so much of the legal complications and other things, the multidisciplinary approach is very important. People will like to have an opinion of the experienced people, so that they should not be involved into any legal hassle later on. So that's why the different forums are also required. Anesthesia cannot go independently in the future. You have to have other specialties involved with you. There is one very good book about the anesthesiologist manual for the surgical procedures. I think every PG should read that book, because once you know the surgical steps where your anesthesia is very, very vital. So those books, I think, even if you didn't get time in your PG, during your SRships or later part of life, that book is very important. The anesthesiologist manual for the surgical procedure. I read that book in 2002. It was such a good book that it really helped you in, giving some knowledge about the surgeon's steps, the surgical steps. Because medical life is not complete, because other specialties have their own dominating points, you have your own points. So where we have to land commonly and to compromise at certain level, those can be known only when we know the ins and outs of other specialties also. That is how to go about in the future. When you are going to frame guidelines, when you are going to frame some advisories, when you are going to improve your anesthesia practice, you should have knowledge of all those things. That's a very, very important part. That's how we should go about it. I think the final comments, Dr. Mohan, want to say something before we close this class.
So, Madhuri madam said correctly, patient should go under physical examination and cardiological examination, like 2D echo, which is very simple and non-invasive test, which can be done to avoid all these consequences.
Yes, sir. Definitely. Thank you, everyone.
Thank you.
Dr. Panna, you want to say something again?
Yes. Yes, I just wanted to say that abroad there are people who have suffered from peripartum cardiomyopathy. Those patients have formed groups, and there are lots of videos available, and they give support to each other. They discuss their disease with each other, and they also discuss about future planning, and also there are lots of videos if you Google search, but they have formed groups.
I think
Thank
those
you.
are good for those people who have those diseases, rather than we
Yes,
people.
yes.
So
Yeah,
because
no, this is just a
because
general knowledge.
Long-term
it
rehabilitation, yeah.
depends
Yes,
upon the society also, the
yes.
awareness, the literacy part, the economic status of your nation also. Those things I think decided accordingly, and it's a good thing. Patient to patient awareness, definitely. But anesthesia awareness is very important. Today we are being held by Dr. Neeta Bose madam and Dr. Dharatana madam, ably supported by Dr. Zalak Patel. So thank you very much. So, ma'am, we always convey our wishes to the presenting faculty, and right time to say now good night to everyone. And we always end by saying, long live ISA.
Long live
Long live
ISA.
ISA.
Thank you, sir.